about. Okay, so we're going to look at the effects of positive pressure ventilation on hemodynamic values. Okay? And one of the hemodynamic values that we're going to talk about is CVP. Okay? And CVP stands for central venous pressure. Central venous pressure. It is the pressure on the right side of the heart. Pressure on the right side of the heart. Okay? It is used to monitor the function of the right heart. So anytime something is going wrong in the right heart, it will be reflected in the CVP value. Okay. For instance, if you have fluid overload, your CVP will go up. Because anytime you have a lot of fluid, the pressure goes up. If you have hypovolemia, where you don't have enough volume, your CVP value will go down. Okay? So just remember that it is the pressure that is used to monitor the function of the right heart. Okay? So normal value for CVP is 2 to 6 millimeter of mercury, or 4 to 12 centimeter of water. Okay. On the exam, you gotta be very careful because sometimes they may give you the value in centimeter of water or maybe millimeter of mercury, so you gotta know which one they're talking about. Okay? Now, positive pressure ventilation, or any type of positive pressure, increases CVP. Now, the CVP is the pressure that is responsible for the blood to return to the right side of the heart. Okay? The lower the CVP, the higher the venous return. The higher the CVP, the lower the venous return. So, positive pressure ventilation increases CVP. Okay, therefore, decreases venous return to the right side of the heart. Okay? So, when the venous return decreases, your cardiac output will decrease. And if your cardiac output decreases, your blood pressure will decrease. And perfusion to organs and tissues will decrease as well. So again, let me repeat that one more time. Positive pressure increases CVP, decreases venous return to the right side of the heart, therefore decreases cardiac output, therefore decreases blood pressure, and then decreases perfusion to organs and tissues. When somebody is on the ventilator, and even you at peak, in the amount of 10 or more, that even causes more decrease in venous return. Okay, so people will compound the problem there. Okay, so we have to be careful now, because one of the things that we monitor when we are giving a patient PEEP is cardiac output. Okay, when your cardiac output drops, you're going to have to back up on your PEEP as well as your blood pressure. Okay. Any questions about that? CVP. Yeah, we're going to do it in detail when we start the hemodynamic course. Okay? Now, here is a spontaneous ventilation. Now, anytime you're breathing spontaneously, or you're breathing on the ventilator on a spontaneous mode, it doesn't affect your cardiac output. Okay, because what happens is that if you're breathing in spontaneously, anytime you breathe in, you create a negative pressure inside your chest. That negative pressure decreases the CVP and then causes more blood to return to the right side of the heart. okay? So for instance, let's say that your CVP now is 6, and then you want to take a point. You create that negative pressure. Let's say I created 2 there. So that takes away my CVP down to 4. Okay? As you all know, for fluid or gas to flow from one end to another, let's say point A to B, the pressure here has to be higher than the pressure here before it can flow. Okay, so now I have the CVP reduced to 4, so blood coming from the heart, okay, excuse me, from the lungs to the pulmonary side will flow easier towards the right side of the heart. So that's what we get. You create negative pressure when you breathe in spontaneously. That decreases your CVP and then causes more blood to return to the right side of the heart. Now, if you're on the ventilator, that's different because you're getting positive pressure instead of creating that negative pressure. If you're on the ventilator, you don't breathe spontaneously, always, the diaphragm is not contracting actively. So positive pressure ventilation increases that CVP, like if we started with 6, now you're on positive pressure, that will make it 8. So it kind of like the blood has to go up the hill to return, okay? So spontaneous breathing enhances cardiac output, okay? Negative pressure ventilation is where you put negative pressure around the chest, okay? And then that negative pressure goes inside the chest to decrease the CVP, okay, then causes blood to return to the right side of the heart. So negative pressure ventilation will affect your cardiac output. It will decrease your cardiac output, but not as much as the positive pressure ventilation will do it. The reason that the negative pressure ventilation will decrease your cardiac output is because the negative pressure applied to the chest, the negative pressure applied to the chest causes blood to pool around the stomach. So not all the blood makes it back to the right side of the heart, okay? But now, so that mimics a spontaneous breathing because you're creating negative pressure. You're putting negative pressure, just like when we're breathing spontaneously. But now with positive pressure, okay, you are putting positive pressure inside the chest, okay? Therefore, that positive pressure is transmitted, okay, to the great veins, which then increases your CVP, okay? And then causes a decrease in venous return, causes a decrease in cardiac output, causes a decrease in blood pressure, and a decrease in perfusion, okay? So that's one of the hemodynamic values, CVP, central venous pressure, the pressure on the right side of the heart. It is used to monitor the function of the right heart. If you have normal value, it means that your right heart function is good. If you don't have normal value, then it means that your right heart function is not good. Just very easy, okay? And then the next question that we need to look at is the PAP pressure, okay? Pulmonary artery pressure. Pulmonary artery pressure. Now, this is the pressure that is inside the pulmonary artery, or the pulmonary system, if you want to say that. So we use it to monitor the function of the lungs and the pulmonary artery. If there is anything going wrong inside the pulmonary artery or inside the lungs, it will be reflected in that pressure. For instance, a patient has pulmonary embolism. That's pulmonary embolism. That pressure will go up. A patient has pulmonary edema. That pressure will go up. A patient has pulmonary congestion. That pressure goes up. A patient has pulmonary obstruction, anything pulmonary, okay? will be reflected in that pressure. Okay? Now, normal value for that is 25/10. Okay, it is the blood pressure of the right heart. The 120/80 is the blood pressure of the left heart. Okay, 25/10 is called the pulmonary blood pressure. 120/80 is called the systemic blood pressure. Now, all we know about is the systemic blood pressure. Not a whole lot of people know about the pulmonary blood pressure. Okay? But normal pulmonary blood pressure, the PAP pressure, is 25/10. Okay? So, positive pressure ventilation increases PAP pressure because it causes compression of the pulmonary artery. The more positive pressure that you are adding to somebody, the more constriction of the pulmonary vasculation. So that's why the pressure goes up. Anytime the diameter of a vessel decreases, the pressure will go up. So that's what we get right here. And consequently, it increases the PVR. Now, PVR stands for pulmonary vascular resistance. Now, pulmonary vascular resistance is the amount of resistance that the right ventricle will have to work against in order to eject blood into the pulmonary artery. So we call it afterload. Now, the word afterload means resistance, period. That's what afterload means. Resistance. So it is the amount of resistance that the right ventricle must work against in order to eject blood into the pulmonary artery. So I'm going to draw it this way. Okay? Let's say that this is the heart. So this is the right ventricle here, and then we have the pulmonary artery, and then there's the lungs over here, okay? So now, this guy here has to pump blood in here, okay? So when the diameter of the pulmonary artery decreases, let's say it goes from like this to like that, because you're using too much pressure, okay, too much PIP or too much PEEP. It means then that this guy would have to work harder to move the blood through the narrow vessel. So the resistance goes up. When the vessel, the diameter of the vessel decreases, resistance goes up. So this guy works very, very hard. You know, the muscle there will begin to swell up. Just like if you're working out. If you work out a lot like that, or you're exercising your muscle, you build more muscle. So over a period of time, if we don't do something about that, we're going to have right heart failure. Okay? Because you have muscle atrophy. So that's what we're saying there, that if the PAP pressure goes up in here, meaning that the diameter of this has decreased, then the resistance that the ventricle has to work against will also increase. And then that will stress out the right heart. Okay? You end up having cor pulmonale. Okay? So we'll talk more about that in the hemodynamic course, but just know that if your PAP pressure goes up, the resistance that the right heart has to work against also goes up. Okay? Any questions about that? So you probably have heard about pulmonary hypertension. Pulmonary hypertension is when the pressure in the right heart is greater than 25/10. Like if I have PAP pressure that is 40/20, that's pulmonary hypertension. If it's greater than 25/10, okay, basically it's pulmonary hypertension. But now let me tell you this, on the exam, you don't need to be very rigid with your normal values, okay? The numbers we're giving to you are the numbers that are about normal. Okay, now I say 25/10. So on the exam, if you see 26/11, well, that's about normal. 27/12, that's about normal. Okay? But now, if I'm giving 40/20, that's it's not anywhere close to 25. Okay, so that's the way you should approach every normal value that you know. Okay, don't be very rigid. Okay, 1, 2, or 3 points above what you know to be normal, above or below what you know to be normal, don't react to it. Okay? All right. And then let's look at another pressure here. This is pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure. The pressure that is measured as the blood is going back into the left heart from the lungs, back into the left heart. Pulmonary capillary wedge pressure. Now, this pressure is used to monitor the function of the left heart. If anything is going bad or going wrong in the left heart, it will be reflected in that pressure. Congestive heart failure. Well, that's a left-sided problem, so that will affect your PCWP. Mechanical ventilation. That affects your PCWP because we said that mechanical ventilation decreases blood pressure. Okay. Why? Because it decreases cardiac outputs. Okay. Mitral valve stenosis. Well, mitral valve is on the left side. That will affect it. Okay. Hypervolemia. Yes, it will affect it. So anything on the left side will be reflected in that pressure. Normal value is 4 to 12 millimeters of mercury. Okay? An increase in PCWP decreases cardiac output. And that is correct. Okay? Because now, here's the left heart here. You're always going to need volume to build pressure. You use volume to build pressure. Okay? So right here, this goes to the aorta. So the left ventricle here, if this guy is weak, which is congestive heart failure, and it's not able to pump the blood out, it means you're going to have a lot of blood sitting here that is not getting pumped out. As a result of that, you got more fluid in here, so the pressure in here goes up. So that's your PCWP. Okay? Well, we have a valve here, mitral valve, that allows blood to come from here to here. If something happens to it, it's not opening up the way it's supposed to open up. Okay? We have the same problem. Over here we have the aortic valve. If it's not opening up, we'll get the same problem. So anything on the left side will cause the PCWP to go up. All right, so effect of positive pressure on cardiac output and cardiac index. Now, cardiac output is the amount of volume pumped out from the ventricle in 1 minute. the amount of blood pumped out from the ventricle in 1 minute. There is a mathematical relationship between cardiac output and stroke volume. Now, stroke volume is the amount of blood pumped out in 1 beat. Boom, pumps out. How much volume did you get out? And then heart rate is the amount of time, how many times your heart is beating in 1 minute. So if you want to calculate your cardiac output, you take your stroke volume, which is the amount pumped out in 1 beat, okay, multiply it by your heart rate, okay? And then divide your answer by 1,000, and that will give you your cardiac output, okay? Normal cardiac output is 48 liters per minute. 48 liters per minute. Okay. All right, and then let me go ahead and talk about the cardiac index before we start doing the problems. Okay, now cardiac index is a way of individualizing cardiac outputs. It's just a way of individualizing cardiac output. For instance, now, I'm bigger than Kiera, okay? My cardiac output is 5, and her cardiac output is 5. Okay, well, we both, that's normal cardiac output. But it's supposed to be that if you're a bigger person, you have more cardiac output. If you have more body index, you have more cardiac output. So is that cardiac output that I have 5, is that actually normal for me, even though it's normal value? Okay, is it enough for me? Okay, so the way we're gonna find out whether that cardiac output is enough for me is I have to divide it by my body surface area. Okay, you have to index it. Okay, so that's called cardiac index. It's a way of individualizing cardiac output. Okay? Like Brian now, probably a little bigger than me, you ought to have more cardiac output than I do. Okay, it will be normal. Yours may be about 8, mine may be about 6, because you're bigger. Okay? So, the higher the cardiac output, the higher the cardiac index. The lower the cardiac output, the lower the cardiac index. Because cardiac index is cardiac output divided by body surface area. So, one of the questions that you may get on the board exam is, a patient on the ventilator had their PEEP increased from 5 to 10, and the cardiac index dropped below 2. Okay, that's another way of saying that cardiac output has just dropped, because the lower the cardiac output, the lower the cardiac index. Which of the following will the respiratory therapist do? Well, you're gonna have to back up on your PEEP. Okay? So let's do this problem here. It says a patient has a stroke volume of 100 milliliter and heart rate of 70 and body surface area of 2 meters squared. Calculate cardiac output and cardiac index. So right here, I take my my stroke volume multiplied by the heart rate, then that will give me 7,000 milliliter. Then I divide by 1,000, that will give me 7 liters per minute. So that's normal cardiac output. And then to calculate the cardiac index, and then I divide the cardiac output by the body surface area, which is 2 meters squared, and that will give me 3.5. Okay. Anytime something is indexed, basically it means that you're dividing by your body surface area. Okay. Any questions about that? So positive pressure ventilation decreases cardiac output and decreases cardiac index. Because if your cardiac output goes down and you divide it by your body surface area, it's also going to go down. If your cardiac output goes up and then you divide it by your body surface area, it will be more. Okay? So they're both going in the same direction. Okay, now let's look at oxygen transport. Again, we're going to talk more about this in the hemodynamic course. Oxygen transport is the transport of oxygen to the tissue cells. Like when we breathe in oxygen inside our lungs, we breathe it into the lungs, and then the oxygen crosses over into the blood and binds to the hemoglobin. Okay? And then the hemoglobin is responsible for transporting that oxygen down to the tissues where the oxygen is needed. That's why we need it for metabolism. Okay, at the tissue level, the oxygen will diffuse inside the cell, and then you have metabolism going on to produce ATP, heat, and CO2 as byproducts. So, let me see if I can think about that formula. I think it goes like DO2 equals CaO2 times, I think cardiac output. Okay, I better have 1,000 here. So this is 20, and this is 5. Okay, what am I missing? I gotta come up with 1,000 here. Let's see, CO2 times cardiac output. I believe I can get that from you. Let's see here.
Times, I have times 10.
Times what?
I have CaO2 times 10 times cardiac output.
Let me see. Sure, you can do it.
Sorry.
Cardiac output. Oh, okay, yeah, thank you. Well, let me look at it one more time. Sorry. Okay, CO times 10, okay. Yeah, the 10 is the constant. That's what I'm missing. Yeah, I'm missing the constant here. Now, that 10, thank you, Kira. That 10 there is a constant to convert the units to volume percent. That's what the 10 is for. That's what I'm missing. Okay? So the normal oxygen transport is 1,000 milliliter per minute. That's the amount of oxygen that is transported to the tissue cell in 1 minute. Okay? Any questions about that? I think I'm not in the hemodynamic mode yet. That's why I forgot that. All right, so if you look at the formula there, it says that DO2 equals oxygen content times cardiac output times 10. That would mean then that if cardiac output decreases, oxygen transport to the tissues will decrease, right? If cardiac output increases, oxygen transport to the tissues will increase. Okay, here's another question here on what it's saying. The respiratory therapist increases peak from 10 to 15. Okay? And then it goes like, which of the following would you expect? Wait a minute. Which of the following would you expect to drop? Okay? Oxygen transport will drop because you added more pressure. Because your cardiac output will drop, oxygen transport to the tissues will drop. So instead of saying that the cardiac output will drop, they will say oxygen transport to the tissue will drop. The same thing. Because when your cardiac output drops, your transport will drop. Does that make sense? Yeah. Yeah, they're very tricky with the question. They don't sometimes ask it directly. They ask it other ways. Okay? All right. So now the next thing here is the CaO2. Now CaO2 stands for oxygen content, arterial oxygen content. The total amount of oxygen carried in the blood. There are two ways that oxygen is carried in the blood. It is carried attached to the hemoglobin, and it is carried dissolved in the plasma. Okay? So that formula goes like hemoglobin times 1.34 times HaO2 plus PaO2 times 0.003. Okay, see, this is the amount of oxygen attached to the hemoglobin, and this is the amount of oxygen dissolved in the plasma. So there is 0.003 milliliter of oxygen dissolved in the plasma per unit of pressure of PaO2. From here, you're going to find out that there's more oxygen carried by the hemoglobin than is dissolved in the plasma. That's why the PaO2 is not the entire picture of looking whether somebody is oxygenated. If you really want to know whether somebody is oxygenated, look at your CaO2, not really the PaO2. Because if you have all the oxygen inside your blood, but you don't have the hemoglobin to carry the oxygen, you still don't have hypoxia. Okay, so PaO2 gives you a little picture of it, not the entire picture. Okay? So when you work this formula out, like, so hemoglobin normal 14 to 12 to 16 is usually like 12 to 14 for females, 14 to 16 for males. So if we put 15 here, and anything normal here, times 1.34 times oxygen saturation. Normal is 95% or above. You're going to convert that to decimal times PaO2 80 times 0.003. If you work it out, you're going to come up with a number that is between 17 to 20. 17 to 20 volume percent. But what they really call the normal value is 20 volume percent, but the range is 17 to 20. Okay? So on the body exam, the way that we did this, because now you can use your calculators. It used to be that they didn't allow you to use your calculators. Okay? What they will do on the exam is they want you to calculate this without a calculator. Okay? Well, the thing there is that if you look, you got normal hemoglobin, you got normal O2 saturation, you got normal PaO2, okay? Then you look at your options, you pick a number between 17 to 20. That's how you work it. Because if you calculate it, it's going to come in that range. Okay? That thing there can never be less than 5. The arterial oxygen content can never be less than 5. In fact, it can never be less than 10. Unless you died 20 days ago. That's the only way. Okay? So on the exam, you know, they give you 5 or 10, you throw it away. If you inspect your values, they're normal, just don't worry about it, just throw it away. It can never be more than 21, unless you are an elephant. That's the only way. So for any human being, it can never be more than 21. In fact, the highest is 20.9. So on the exam, give you one that is more than 21, throw it away. That's not possible. There's no way. Okay, but now, thank God they're giving you calculators now. You can just plug in the values and work it out. Okay, but if you want to make it easier for yourself, that's what you do. Like now, if I'm given 10 here for hemoglobin, I'm giving 70 here, I'm giving 70 here. They are all abnormal values. If you work it, there's no way it's going to come out with a number between 17 to 20. That's not possible. So in that case, I will not pick a number that is between 17 to 20. I have to pick something that is lower than 17. Okay? So mechanical ventilation, positive pressure ventilation, decreases arterial oxygen content. The more pressure, the lower that number. Okay? And then we'll go to PVO2. PVO2 is the partial pressure of oxygen in the venous blood. Just like the PaO2 is the partial pressure of oxygen in the arterial blood. Normal PVO2 is 35 to 45. When the PVO2 is decreasing, cardiac output is decreasing. Okay? Now let me tell you another thing. If you really want to know how well the lungs are working, you get arterial blood gases. If you really want to know how well your heart is working, you get your venous blood gases. Okay, so we use the venous parameters to measure the function of the heart. We use the arterial values to measure the function of the lungs. Okay? So if my PVO2 is dropping, cardiac output is dropping. Okay? If my CaO2 is dropping, cardiac output is dropping. Okay? And then we go to CVO2, the total amount of oxygen in the venous blood. Okay? Same formula, but other than here we're going to put SVO2, arterial oxygen, venous oxygen saturation. SVO2 will go here, and here we'll put PVO2, and then we calculate that. Don't worry, we're going to do it in details in hemodynamics. And then you get 12 to 16% 12 to 16% for your venous oxygen content. Okay? What they like to call the normal is 15, but the range is 12 to 16. Okay? If your CVO2 is decreasing, cardiac output is decreasing. Okay? Any questions about that? And then we go to SVO2, venous oxygen saturation, 65 to 75%. The amount of oxygen saturation in the venous blood. SaO2 is the amount of saturation in the arterial blood. So inside the venous blood is saturated with oxygen 65 to 75%. When the SVO2 is decreasing, cardiac output is decreasing. Okay? So I want to go over it one more time before we continue here. Okay, so when the CaO2 is decreasing, cardiac output is decreasing. When the PVO2 is decreasing, cardiac output is decreasing. When the CVO2 is decreasing, cardiac output is decreasing. When the SVO2 is decreasing, cardiac output is decreasing. And then we have this other value, which is basically your CaO2 minus your CVO2. Okay. Arterial oxygen content minus venous oxygen content. So now let's say that this is perfectly normal at 20, and this is perfectly normal at 15, so that means that this will be 5. The perfect normal for the difference is 5, but the range is 4 to 6. 4 to 6. So that's the only one that is different. When the arterial to venous oxygen content difference, that's what we call it, arterial to venous oxygen content difference, is increasing, cardiac output is decreasing. Okay? There's a formula called the Fick equation. Yeah, we're gonna work it in the hemodynamic course. Okay, Fick equation. So that's the only one that you really have to remember as being different. Okay? A respiratory therapist increased PEEP from 10 to 15. Arterial to venous oxygen content difference is now above 6. That's another way of saying that cardiac output has just decreased. So you're gonna have to back up on your PEEP. Okay? Any questions about that? One more time, because this is hard for students. When the arterial to estimate oxygen content is decreasing, cardiac output is decreasing. When the PVO2 is decreasing, cardiac output is decreasing. When the venous oxygen content different, venous oxygen, let me back up a little bit. I think I'm moving very fast. Venous oxygen content is decreasing, cardiac output is decreasing. Venous oxygen saturation is decreasing, cardiac output is decreasing. And then the difference is going up, cardiac output is decreasing. Okay? All right, so now, let's look at the mean here. This one here is mean pulmonary arterial pressure. Okay, taking a mean, taking average. Okay? So, positive pressure ventilation will increase, will increase the mean pulmonary arterial pressure. Okay, because positive pressure ventilation increases the PAP pressure. If the PAP pressure goes up, the mean goes up. If the PAP pressure goes down, the mean goes down. Okay, so positive pressure ventilation increases the mean pulmonary arterial pressure. That's the pressure inside the lungs. Okay, because we're compressing the pulmonary artery. And 13 to 17 is a normal range of the mean pulmonary arterial pressure. Okay? Like I said on the exam, if I'm given, 18, 19, well, that will be fine. If I'm given, 12, 11, that will be fine. But if I'm given 25, that will not be fine. If I'm given 9, that will not be fine. Okay, so just pick anything that is very close to what you know to be normal. Okay? Here's an example of how to figure out the mean, and that's the formula there. MPAP equals stroke volume plus 2 times the diastolic pressure. What did I say? Stroke volume? Yeah, sorry. Systolic is what I mean. Systolic pressure times 2 times diastolic divided by 3. The reason that we have to multiply the diastolic pressure by 2 is because the heart spends twice the amount of time that in diastolic than it does in systolic. Okay? That's why we're multiplying by 2. So basically you got 3 things there, and then we're dividing by 3. So that makes it an average. We're taking an average. Okay, so now let's find out what is normal. Okay, and again, there's a formula that says normal plus normal equals normal. Okay, there's a formula like that. Normal plus normal equals normal. Okay, if I want to find out what is normal for MPAP, well, I got to plug in normal value for PAP. Okay, so right here I got 25 for the systolic pressure. I got 10 for the diastolic pressure times 2. That's 20 divided by 3. So I have 45 divided by 3. That's 15. So normal MPAP is 15, but the range is 13 to 17. So remember that formula. Normal plus normal equals normal. Okay? You don't even have to work it out, just like we did a while ago. If I'm giving everything normal for that formula, well, I'll pick an answer that is normal. Just make it easy. And that's what they do on the exam, really. No joke. That's what they do. If you inspect your values, okay, you find out that that's exactly what they're doing. Okay, any questions about this? So, positive pressure ventilation will increase impact. Now, here's the map, the average systemic blood pressure, okay, mean arterial pressure, okay. The same formula, other than now we're using the systemic blood pressure to do it. The 120 systolic pressure plus the 80 for the diastolic pressure times 2, that's 160 divided by 3, so we have 93.3. So that's the normal map, mean arterial pressure. But the range is about 80 to 100, because not everybody has a blood pressure of 20/80. Okay, not everybody. You may be a little lower, you may be a little higher. Preload. Preload is the amount of volume or pressure in the ventricle prior to systole, before contraction. The amount of volume that the ventricle got filled up with before it contracted and pumped out. Okay, it's preload. Okay? If you want to increase preload, you give intravascular volume. Let's say that somebody is dehydrated and you want to give them fluid, you are increasing preload. When you diurese somebody, you are decreasing preload. Okay, so it's just the amount of volume inside the ventricle prior to systole. Afterload is the resistance that the ventricle has to work against in order to eject blood out. Okay? Another way to define that, the easiest way, is impedance to ventricular emptying. I like that one. Impedance to ventricular emptying. Okay? All right, so we have two types of afterload. Okay? On the right side, we have PVR, which is the resistance that the right heart must work against in order to eject blood into the pulmonary artery. That resistance is about 150 to 350. Okay, if you have it more than 350, then it's going to be harder for the right ventricle to move blood into the pulmonary artery. You have a lot of afterload. What kind of drug would we give for that? Let's say your pulmonary artery, normal diameter is supposed to be like that, but now, because of hypoxemia or other reasons, it decreased that way. What kind of drug would we give to make it dilate back this way so that we can Yeah, it's a vasodilator, yeah. But what's a good example of pulmonary vasodilator? Nitric oxide. Nitric oxide is a good drug for that. Okay? Viagra is good. What's the other one? Cialis is good. Now, do you know that COPD and pulmonary hypertension coexist? If you have COPD, you have chronic hypoxemia. Because you know what the range of the normal PaO2 is. I mean, that's your normal PaO2, but that's not normal PaO2. So, as a result of that, their pulmonary blood vessels are always constricted. So, instead COPD, they end up with pulmonary hypertension. That's how come that when you see them, they're always like on a couple of liters of oxygen, because oxygen is a vasodilator. Okay? So now that tells you something about that COPD patient. When you go to the hospital and look at their look at their MAR, medical administration record, and you see that they are ordered to receive Viagra or Cialis, it's not because they love to have sex. It's just because it helps with their pulmonary hypertension. Any questions about that? And then we have systemic vascular resistance. The afterload of the left side of the heart is huge. It's huge because the left heart does more work than the right heart. Okay? Now, if that resistance is greater than 1600, that would mean that the left ventricle will have to work harder in order to eject blood into the aorta. Also, we have to give a vasodilator as well. But we have systemic vasodilators, like nitroglycerin will be one of them. Nitroprusside sodium, nitrate will be one of them. Okay, we're going to go over pharmacology again in hemodynamics. But you give vasodilators when the resistance is high. Okay? Effect of positive pressure ventilation on lung compliance. Now, if you have very low lung compliance, meaning that your lungs are very stiff, okay, you will not see a lot of side effects of positive pressure ventilation compared to if you have a very high compliance. Okay? So, the stiffer your lungs are, the less effect that you see on your hemodynamic values. Like somebody who has ARDS, okay? Their blood pressures will not be affected, okay, more compared to somebody who has COPD, okay, for the same amount of pressure, okay? So that's what this is all about. The stiffer your lungs are, the less side effects that you will see from positive pressure ventilation, because the stiff lungs absorb the pressure, okay, and it doesn't affect your blood pressure. Okay, now this is the reason why we're doing this, because they have it hooked up to mechanical ventilation questions. So let's go over a few of them here. It says that a 25-year-old, 58 kg female is admitted to ICU after an emergency C-section. The patient is receiving mechanical ventilation via volume control ventilator. The current ventilator settings are mode, SIMV, 600, frequency 12, FIO 250, people 5. Here's the ABG here. So we have acceptable ABG, seat-based balance with moderate hypoxemia. Okay, now, see how they have the hemodynamic values there? You should not ignore those. Okay, you always have to read them. Now, CVP, is that good? That's 7. What do you think is good? Remember, it's 2 to 6 millimeters of mercury or 4 to 12 centimeters of water, right? So that would be good, right? So if you go back here, what that means then is that that P4-5 is not affecting the right heart. So we're okay. Then we move on to the lungs here. PAP 13, is that good or bad? That's mean. That's good. We said 13 to 17, right? So the P4-5 is not affecting the lungs. How about cardiac output? Is that normal cardiac output 4.5? Yes, because it's 48. So that P4-5 is not causing any problems. So we'll go here, it says the respiratory therapist should recommend increasing which of the following. Well, what's the problem with blood gas? They don't have, they don't have enough oxygen. That's the problem. So what would you do here What would you choose? D. D, very good, because we'll have to get to 60%. The patient is not up to 60% yet. Okay? That's another one here. A 70 kg male patient is receiving mechanical ventilation via volume controlled, pressure limited microprocessor ventilator. The current ventilator settings are add volume 700, frequency 10, FIO to 65, people 5. The blood gases are good, other than we have moderate hypoxemia, so that's our problem here. And then O2 saturation of 87. CVP 7, well, that's good. It means that the level of pills that we currently have is not affecting the right heart. PAP, well, that's good. 13 to 17, that's good. 14 is in that range. Cardiac outputs, that's good. Okay. The respiratory therapist should recommend increasing which of the following. How would we give them more oxygen?
C.
Huh?
C.
C. Why?
502s.
Yeah, because the FiO2 is already above 50 to 60, right? If a patient is going to be on any FiO2 that is 60 or above, they're going to need PEEP. Okay? Okay, number 3 here. A 60 kg female is receiving mechanical ventilation. The current ventilator settings are tidal volume 650, frequency 10, FiO2 60, PEEP of 10. Here's the blood gases. PaO2 is low. That's the only problem. We have moderate hypoxemia here. And then looking at my CVP, 10 centimeters of water. Well, that would be good, because we said 4 to 12, right? All right. PAP 17. Well, that's good. Venous oxygen content. Well, that's good, right? 12 to 16 is what we said. That's good. So the PEEP of 10 is not causing any problems right now. What are we going to do here to give them more oxygen? What do you think, Brian?
B.
B? Yeah. You're going to increase PEEP. You keep on increasing PEEP until you get the PaO2 that you're looking for, or you have a side effect. Okay? That's another one. A patient is receiving volume controlled mechanical ventilation in the SIMP mode with flow triggering. What difference does that make? The current ventilator settings are tidal volume 550, frequency 12, FIO to 60%, PEEP of 15. Here are the blood gases. Normal acid-base balance with moderate hypoxemia. CVP, that is good. PAP, that is good. Cardiac index, that's good. Cardiac index is 2 to 4. Yeah. So if it is higher than, oh no, it's not high. It's good. 2.7 is good. It's 2 to 4. Okay? But if the cardiac index was higher than 4, well, that's still fine. Because what we worry about in administering PEEP is low cardiac output as well as low cardiac index. Okay? If your cardiac output is high, very high, your blood pressure is very high, your cardiac index is very high, you can give any amount of PEEP you want to give. Okay, we'll worry about low values. What are we going to do to give more oxygen?
D.
Hmm?
D.
D. Yeah, we increase PEEP to 20. Okay, like I said, now keep on increasing PEEP until you get the PaO2 that you want, or maybe you have a side effect. So we don't have any side effect here. Everything is good. And I'm not pleased with that PaO2, so I need to go ahead and add more PEEP. An 80 kg patient in the post-anesthesia care unit, following lower abdominal circle, is receiving mechanical ventilation. Ventilation fillings are as follows. Tidal one 750, frequency 10, FIA to 60%, keep of 20. The blood gases. Normal acid-base balance with normal oxygen. And then I'll look at my hemodynamic values. My CVP is fine. My PAP is 38. Is that good? No, that's very high. It's not even anywhere close to that 17. We're above 17. So that means that that PEEP is causing problems. It's constricting the pulmonary artery. Okay? And then we have arterial to venous oxygen content difference, 11.2. Remember, normal range is 4 to 6. And that's the one that I said that if the value is increasing above 6, cardiac output is decreasing. That's the one that is different. So cardiac output is decreasing. The pulmonary vasculature is being compressed. So we have side effects from the PEEP. Okay? So look at my PaO2. Okay? It's normal. So let's go here. So what I need to do now is what? Because now, if I get down to a PaO2 of 80, I will still be fine because that's normal oxygenation. So I need to back up on something here to take away some of the pressure from the heart. Which one would you do?
C.
Hmm?
C.
C. Does anybody know why we have to do C?
Because you do it gradually.
Yeah, because I told you many times, right? You do it gradually. If you're going to go up, you go up gradually. If you're going to come down, you come down gradually. On everything, not just PEEP. Tidal volume, FiO2, medication, everything you want to think about. Okay, always go up gradually, always come down gradually. Okay? A patient is being mechanically ventilated at the following settings. Tidal volume 750, frequency 10, FiO2 60, PEEP of 20. Here we have normal acid-base balance with normal oxygen as well. CVP, I forgot the unit and that one, make it 10 centimeter of water. That's good. PAP 28 mean, that's very high. Cardiac output 2.5. Is that good?
No.
No, it's below 4. So that PEEP is causing problems. It's decreasing cardiac output. So we have to back up on the pressure here. Okay? Now I have a PaO2 of 87. I can go down by 7 points and I'll still be okay. The respiratory therapy should recommend which of the following? Which one?
B.
B, right? Mm-hmm. Decreasing PEEP to 15. Okay? A 75 kg patient with myasthenia gravis is being mechanically ventilated at the following settings. Tidal volume 750, frequency 12, FIA to 60, PEEP of 20, high time 2.5 seconds. And then here are the blood gases. Okay. New PAP, that's normal. CVP, that's normal. I mean, PCWP, that's normal because that's 4 to 12, so that's normal. Cardiac index, that's also normal because that's 2 to 4. We need to give them more oxygen. What are we going to do?
Do you have your key with you, Dr. O?
Good?
Do you have your key?
Yeah.
Come get your pen, you got a little chuck.
Yeah. Hold on, Joe.
Fake blood all over the place.
So how do we give them more oxygen? What option there will give the patient more oxygen? Come on, guys.
D,
Huh?
D,
No, not quite. How about increasing the FiO2 to 70? That's the only choice you got. Look, it's never like you can go up on oxygen more than 60%. That's not what we're saying. What we're saying is that at 60%, you're better off using pressure.
Thank you, sir.
Thank you. But if for some reason you cannot use pressure, then you use more FiO2. That's what we're saying. If you go to the health hospital, you see people on the FiO2 up to 100%. It's because for some reason, if you add PEEP, they're gonna have a decrease in cardiac output. So right now, this is the only choice that we have that will give the patient more oxygen, increasing the FiO2 to 70%. Now, in order to catch up, your quiz number 3 that we have on Thursday, I will give it to you today. It will be a take-home quiz, okay? And then you bring it back on Thursday. How about that? That will help me catch up, okay? So on Thursday, we're gonna have time to do more stuff. All right, so we're gonna take a break now. Let me go print out the quiz.